Good afternoon, everyone. Today we'll be discussing a very interesting case which we managed in the recent past in our department. So this is a 2-year-old baby boy who was absolutely well until 1.5 years of age. He was growing normally. His developmental milestones were all right. There was no history of any recurrent infections, any contact with TB, or any history of trauma or any other major illness in the past. 6 months back, he developed complaints of fast breathing, cough, and fever, which continued for a week's time. For these complaints, he was evaluated at a local hospital, and the chest X-ray done there showed a massive cardiomegaly. An echocardiogram which followed showed massive pericardial effusion causing collapse of right atrium and right ventricle, leading to tamponade. Hence, to remove the massive pericardial effusion, a therapeutic pericardiocentesis was done. The analysis of fluid obtained there showed that it was reddish in nature, had a high protein content, and was lymphocytic predominant. Based on these findings, he was empirically started on TB medications. However, he never became well in the meantime. His symptoms continued to persist and he required hospitalization 3 times in last 6 months. His breathing difficulty continued to worsen by the time he had come to us, despite a good compliance to anti-TB medicine. Hence, he was brought to AIIMS emergency. When we saw the child, he was tachycardic, he was tachypneic and has significant respiratory distress. There was significant hepatomegaly. On cardiac examination, there was significant cardiomegaly and the heart sounds were muffled. Although he maintained his blood pressure and perfusion, and on a general survey, there was no evidence of any musculoskeletal abnormality or any syndromic feature. This is the chest X-ray in the emergency room, which showed a massive cardiomegaly, very similar to the X-ray which was done 6 months back. An ECG which was done showed a normal sinus rhythm with generalized low volume complexes in all the lids. We did an echocardiogram in the emergency, which was showing a massive pericardial effusion with tamponade causing RA and RV collapse. We immediately had to drain the pericardial fluid. About 300 ml of fluid was drained. And to continue the drainage, we had to leave a pigtail in situ. These were the echo loops showing apical 4-chamber view and a subcostal 4-chamber view showing a significant amount of pericardial effusion even after drainage in the initial part. So this was the surprise. We drained a milky, thick, yellowish fluid. So for the first thought, we thought this is chyle, which is nothing but a lymphatic drainage and collected in the pericardial fluid possibly. But was it pseudocyle? Pseudocyle, on the other hand, is an exudative fluid. It is a complication of chronic pericardial effusion caused by inflammatory conditions like TB and rheumatoid arthritis. Sometimes even pyopericardium can look like this, thick and yellowish and milky in appearance. So to solve our dilemma, we went ahead with pericardial fluid analysis. The cell counts were elevated with lymphocyte predominance. The sugar was normal, but the protein level was elevated. There was no evidence of any bacterial infection or any microbiological evidence of TB in the fluid. However, it is the lipid value in the blood, in the pericardial fluid, which clinched the diagnosis. The triglyceride level were hugely elevated up to 1600 milligram per deciliter, and the cholesterol level in the fluid was more or less normal. This gave a ratio of cholesterol to triglyceride less than 1, suggesting that it is chyle and not pseudocyle. We did some baseline investigations which showed a normal leukocyte count and a normal eosinophil count as well. Platelet counts were normal. The serum lipid profile was normal and there was no evidence of any systemic inflammation. The C-reactive protein and other inflammatory markers were nearly normal. So at this point, we had a young child who had a massive chylopericardium. So looking into the etiological consideration, it could be primary, which can be caused by congenital lymphatic malformations, but the more common ones are the secondary ones. Based on the whatever investigations we had done so far and the clinical evaluation, we had already ruled out trauma, we had ruled out thoracic surgery, there was no syndromic association found, and there was no pseudokylothorax as well. With this, we went ahead with some more investigations. The ultrasound Doppler of the upper limb veins were normal, so the subclavian vein thrombosis was ruled out. The test for filariasis were also negative, hence filariasis became less likely. So we went ahead with CT chest to look for further evidence of any mass or tubercular lesion. I would now like to call Dr. Mansi, my cardiac radiology colleague, for taking us through results of radiological investigations.
Thank you, Dr. Satrupa. So these are the images of CT angiography. So here we can see that the arch vessels were grossly normal. There was no evidence of any mass lesion seen, and also bilateral lung fields were normal. There was no parenchymal lesion seen in bilateral lung fields. And also this we can see there is pericardial effusion with pericardial drain in CT. So thereafter, a MR lymphangiogram was done for this patient. In MR lymphangiogram, basically first we do non-contrast scan followed by a contrast enhanced scan. So in the non-contrast scan, the main sequence which we do is heavily T2 weighted sequences. The first is the T2 weighted imaging, which demonstrates that there is presence of a ill-defined soft tissue mass lesion which was seen from the lower neck till the subcarinal region, and this lesion was hyper intense on T2 weighted images. This is the space image, which is another T2 weighted image, which also demonstrates similar findings of a ill-defined soft tissue lesion, which is seen from the lower neck till the subcarinal region, and it was again hyper intense on space images. And this is a T1 image which better demonstrates the insinuating soft tissue mass in the mediastinum, which was draping along the arch vessels and the trachea. So thereafter, a dynamic contrast enhanced MR lymphangiography was performed for this child. So in this technique, we place a 26 gauge needle at the junction of the cortex and the medulla of the inguinal lymph node. So this is the needle tip which was placed at the corticomedullary junction, and thereafter a 0.1 millimole per kg gadobinate dimeglobin, which is a GAD-based contrast agent, is injected into each lymph node after 1:1 dilution with normal saline. So half of the amount is injected into each node, and we have to be very sure that we have to give slow hand injection at a rate of 0.1 to 1 ml per minute. So this is the second image which demonstrates that after injection of the contrast, the lymph node has swollen and there was contrast in C2. Thereafter, sequential images are taken, and this is the image which is at L1, L2 level, which demonstrates a oval shaped cisterna chyli in this child. And thereafter, we can see that this is the thoracic duct which was seen only till the subcarinal region. That is, this is the thoracic duct which is seen in the T6 level. However, in the superior aspect, that is, if we see at the T4, T5 level, we could not demonstrate the thoracic duct. It was either absent or atretic. Instead, what we could see is this hyper enhancement. This is basically the lymphatic reflux which is seen into the mediastinum, and we can see that it has draped along the arch vessels and the aorta. So as already told, that this duct was only visualized up till T6 level. So these are the coronal images, again demonstrating the similar findings, that there was presence of enhancement in the mediastinum and there was contrast reflux in the mediastinum along with the reflux along the bronchovascular bundles. So as there was presence of lymphatic reflux and we could not visualize the thoracic duct, so we gave a provisional diagnosis of central conducting lymphatic enamel.
Thank you, Dr. Mansi. With the investigations and the evaluation so far, we have a 2-year-old child who has an abnormal mass in the mediastinum of lymphatic origin. The differential diagnosis for such a mass could be a lymphangioma, which is a well-defined focal proliferation in a localized region. In our child, as already discussed, it was a diffuse proliferation in the mediastinum. The other possibility could be lymphangiectasis, which is abnormal dilatation of lymphatic vessels. Usually, the primary form of lymphangiectasis presents at a very young age and is mostly fatal. On the other hand, lymphatic dysplasia syndrome occurs mostly in adults and present most commonly with chronic lymphedema. So amongst these, lymphangiomatosis, which is a diffuse proliferation of in mediastinum of lymphatic tissue, was the most probable diagnosis considered for this patient. Now, lymphangiomatosis is a diffuse proliferation of lymphatic tissue. Amongst the lymphangiomatosis, the Gorham-Stout disease usually involves bony skeletal system with lytic lesions and causes CSF leaks and meningitis. The generalized lymphatic anomaly variety of lymphangiomatosis also involves the skeletal system and commonly involves the pulmonary system as well. On the other hand, Kaposiform lymphangiomatosis is a very aggressive disease. It has multi-system affliction and affects bone, hepatic dysfunction, causes pancytopenia. Hence, this was a very less likely possibility in our patient. Whereas central conducting lymphatic anomaly is an anomaly of the thoracic duct primarily. As described already, the thoracic duct was not visible beyond the subcarinal level, and there beyond that there was collection of lymphatic tissue. Hence, and in this condition usually there is no other systemic involvement. So this was considered as the most likely possibility in our patient. To, confirm and refute other diagnosis, we had done a skeletal survey as well, which is showing essentially normal bones with no evidence of any lytic lesions. So far, we have discussed about a 2-year-old child who presented to us in emergency with massive pericardial effusion, required therapeutic pericardiocentesis. We had ruled out the secondary causes of chylopericardium, and lymphangiomatosis is the most probable diagnosis. While we were investigating, we had already started dietary management, which consisted of low fat, high protein, medium chain triglyceride rich diet. When we looked into the definitive therapeutic options for this patient, when there is a masked lesion, an obvious answer would be the surgical excision of the mass along with ligation of the thoracic duct. However, the mass had diffuse margins which would not be amenable to surgery very easily, and we were not sure whether ligating the thoracic duct would give a desired response. The other option which we considered was an endovascular intervention, but there was no specific leak site seen which could be embolized by an intervention. Hence, the option which we were left was a drug therapy, and amongst them, the mTOR inhibitors is a therapy which is useful. So, sirolimus is a drug which has recently been shown to be effective in lymphatic malformations, and hence we went ahead with this therapy at a dose of 0.8 mg per meter square body surface area given twice a day. Moving into the hospital course, we can see that we had started dietary management early in the hospital course, almost by day 4 of hospitalization. Once a dietary management was started, the amount of pericardial fluid did reduce, but it continued to remain same in a moderate amount throughout. That is why we had to go for a definitive management in the form of sirolimus. Once sirolimus was initiated, there was a drastic reduction in pericardial fluid that happened. Child had significant symptom resolution. Meanwhile, while the child was in hospital, the sirolimus drug levels were checked and therapeutic targets were maintained. Septran prophylaxis had to be started for the patient for pneumocystis pneumonia prophylaxis. We continued to check the blood counts, the liver test, and the lipid profile to look for any adverse events sirolimus can cause. And then the child was discharged at day 24 of hospitalization. So as we can see, this is the apical 4-chamber view, which is showing marked reduction in the pericardial effusion with very minimal fluid around the ventricle. We followed up the child diligently in our OPD, and as we can see, the sirolimus drug levels were gradually attained the therapeutic range of 5 to 15 microgram per liter. Every time the drug was increased by 20% in the visit. And this was done until the 15th of April. However, in between, in one of the visits, there was a mild elevation of triglyceride level, which was managed only conservatively. But then, as we all know, the second wave of COVID-19 pandemic hit all of us, and the child was lost to follow-up for a while until 15th of July. In the meantime, we had managed to contact him via telephone and to ask about his medication compliance. Finally, when the child returned to us in second week of July, we saw that he was in remission, and we can see that chest X-ray at review was showing a nearly normal cardiac size compared to what he had come earlier with. And this was the echo when he had come to us in July, showing minimal pericardial effusion and a normally functioning heart. So we also repeated a dynamic contrast enhanced MR lymphangiogram to look for the change in the size of the mass which was seen earlier. This is the picture in the earlier part of the course which was showing marked enhancement, and these are the pictures just before in last month showing very minimal enhancement around the left bronchus. The mass as if has completely vanished. And the ultimate physician reward is a healthy child. The child is currently gaining weight, and he is currently on sirolimus therapy of 1.8 mg per day. A long-term sirolimus therapy has been planned, although we are not very clear on what should be the duration of sirolimus therapy for this patient. So the diagnosis of chylopericardium is done by appearance of the fluid to be milky yellowish with elevated triglyceride level of more than 500 milligram per deciliter, along with a normal cholesterol level in the fluid. And there should be no evidence of any infection in the fluid, as well as the count should be lymphocytic predominance. With these criteria, we can diagnose chylopericardium, or for that matter chyle, with a sensitivity and specificity of nearly 100%. On the other hand, pseudochyle is a complication of a chronic exudative pericarditis, which has stood for a very long time, and over time it becomes rich with cholesterol. In this case, the total cholesterol to triglyceride ratio will be more than 1, and it is usually caused by chronic inflammatory conditions like TB and rheumatoid arthritis. Now, sirolimus is the agent that made the difference in this patient. So, a brief discussion about sirolimus. Sirolimus is an mTOR inhibitor. mTOR is a mammalian target of rapamycin, is an protein kinase enzyme. It is one of the key enzymes which regulates proliferation, cell growth, differentiation, and angiogenesis. The vascular endothelial growth factor, which is a known angiogenetic factor, also acts through mTOR. When sirolimus inhibits this particular enzyme, it inhibits angiogenesis through inhibition of vascular endothelial growth factor. Now, the use of sirolimus in lymphatic malformations is relatively recent, and there is very less data, mostly case reports in this particular scenario. This is a systematic review of about 71 patients, which showed that at least 80% of patients in this particular group showed at least partial response to sirolimus in lymphatic malformations. The recommended starting dose is 0.8 mg per dose per meter square. The mean time of response reported is 25 days, which could be as early as 8 days as seen in our patient, or as long as 2 months. The median duration of treatment is 8.5 months, although this is not very clear from literature as of now. And the most common adverse effects reported are bone marrow suppression and increase in triglyceride and cholesterol level. Now, when we give sirolimus in a child, there are few points which should be a matter of concern to us. The first report of sirolimus as an anti-angiogenetic agent was published only in year 2010, and an FDA approval is present only for children more than 13 years, that too in post-renal transplant patients. We do have some safety data from organ transplant patients, but the use in children, especially the younger ones like neonates and infants, should be done with caution. There are several unanswered questions in this particular area, like what should be the duration of therapy? We know that mTOR is a key cellular proliferation regulator. Does it have any effect on growth and development? Is it safe to give give it in neonates and small children on a long-term basis? And what should be the optimal dose and target therapeutic level in lymphatic malformations particularly? So I would like to conclude saying that this case demonstrates a rare clinical entity of chylopericardium, which presented at a young age to us, and it is caused by even rarer complex lymphatic anomaly, which was treated successfully by a newer therapy, sirolimus. Thank you. So the lymphangiomatosis per se is a very rare entity. I mean, we have very few reports from some Western centers, that too included just case series of maybe 30 to 40 patients from a single center. So that is a
Because
large.
why I'm asking this question is, I think recently 2 years back, 1 year went on in Corona pandemic. We have reported a lymphangiomyomatosis was operated at our institute, 2 cases.
Right. So, lymphangiomyomatosis, I believe histological will be different. This
Same
is
lymphatic malformation with presence of smooth muscle cells at the body.
yes, sir. Yes, sir.
Lymphatic malformation
So if
in the
we take
mediastinum
right,
causing
sir.
pericardial effusion, and it got operated.
Right, sir. So
we
if
have
we
these
take as
two.
a group of lymphatic malformations, possibly it will be much more common. But if we take lymphangiomatosis, that particular subset, histological subset, would be a rare diagnosis.
For past 2 years, the operate in yes, no, no, I don't. It is not operated. It is treated on sirolimus, and those 2 cases got operated.
Right, sir. So there are few reports which would require operation, but in this case, I had already discussed that the surgical management would have been very difficult. The mass was extensively diffused.
No, I am talking about the incidence. How often do you see? The treatment is different parts. One more question what I have is, then did you observe wound healing in these patients? Because you are providing anti-angiogenic mTOR inhibitors. Children are often used to have many kind of abrasions. So any impairment in wound healing in these patients?
Sir, we did not do any surgical management for this patient. However, if we see that
Did the patient complaints of anything
no,
regarding this?
no, we have been following him for since last 4 months now after sirolimus therapy, and he hasn't complained. You know how children are; they will get wounds while they are
That's what
playing.
I am
But
asking.
he hasn't complained of any such, and we have been keeping him in a very close follow-up. He follows with us almost every week, and since last 1 month, every fortnightly, he's been following up with us.
If he complains about delayed wound healing and all, I
Yes,
think it should be.
yes. So far, he hasn't complained of any such event.
Thank you.
I think I should begin by Dr. Kothari wants me to take off my mask. I don't know why, but so I think I should begin by complimenting you on a wonderful presentation that was, when I saw the title, I was a little doubtful about what I'm going to be listening to. Will I be bombarded with a large number of acronyms? But this was so clear, everything was spelled out, and you took into account the fact that this is a group of non-cardiologists when I think you made your presentation. And that's something I think we should all remember when we come to this forum. And of course, the real test is that I think I understood most of what you said. My question is, you've raised the concerns about sirolimus. Some of them Sudhir has referred to. The other thing is, because we see lymphatic and vascular malformations in children presenting on the skin, sildenafil is also mentioned as a drug that works for complex lymphatic malformations. Does it work for this kind? And did you consider using that instead of sirolimus, or is there a plan to shift from sirolimus to sildenafil? That's one question. And the other one is easier, so you can take that first. How much does it cost the child's family every month for this treatment?
Right, sir. So sirolimus, for him, this cost is coming to nearly about 5,000 per his weight. And regarding sildenafil, sir, there are reports which are using sildenafil and some other drugs like trametinib, which are monoclonal antibodies. But the largest data available for lymphatic malformations is this. So that is why we felt that it is safer to use this particular drug in the lymphatic malformation condition. Sildenafil,
data for sildenafil is more for hemangiomas. In some of the ocular and skin hemangiomas it is used, but not for the invasive and non-visible masses like this. So I think for the kind of response we want in such lesions, I think sirolimus is a better drug because we have a response. And as of now, we have not thought about sildenafil, but yes, we'll again go back and see whether there is a merit in shifting to a drug which has a lower risk profile and probably is much cheaper also. We'll go into that, sir.
I can make a couple of points. One is that we discussed in department meeting also that the FDA has also approved sirolimus for some kinds of lymphatic.
Yes, sir. So it has approved lymphangioliomyomatosis. It has been approved.
Right.
In adults, sir.
Right.
But not lymphangiomatosis. Although we do not have a tissue diagnosis for this patient, but it is the lymphangioliomyomatosis for which FDA has approved.
So that's the second point I wanted to make, that didn't you consider taking a biopsy to get a tissue diagnosis in this case?
Yes, sir. So in fact, when we saw the MR lymphangiogram at the first go, we actually contemplated that biopsy could be done. But we discussed with our cardiac radiology team, and the mass appeared to be very, very diffuse, extending into the mediastinal fat. And the location, it has been just encasing the great vessels. And looking into the age of the child, we did not find the risk-benefit ratio to be on the beneficial side. That is why we went ahead with investigations, and then we went ahead with treatment without any tissue diagnosis. Thank you, sir.